Hey guys, my name is Atif Shahnawaz. I'm an internal medicine doctor and I make videos explaining medical concepts in layman's terms. This video is part 3 of my discussion on blood clots. In the first video, I discussed the causes and symptoms, and in part 2, I went over how we make the diagnosis, and in this part, I'm going to go over the treatment options. As always, my focus here isn't just to give you a bunch of facts, but to give you a better understanding of the way that we physicians go about thinking through these problems. If you'd like to see more of this sort of content, please go ahead and subscribe if you haven't already, and click on that like button as well so you can help the channel continue to grow. Now, the main treatment option for blood clots is to give a medication that we call an anticoagulant, which is just a $5 word that means blood thinner. But it's important to understand that the anticoagulants that we use do not dissolve the clot that's present in the body. So these are not clot-busting medications. And I stress this point because I've been asked many times by my patients how long the medicine is going to take to remove the clot. Now, in most cases, the clot will be dissolved, but the body itself does that, and it takes a few weeks for that to occur. The whole point of giving anticoagulants is to prevent more clots from forming and to prevent those existing clots from getting bigger. Now, anticoagulants work by interfering with the coagulation cascade that I talked about in the first video, and the most widely used anticoagulant is called Coumadin, which also goes by the name of warfarin. It's been around for a long time. It's the OG of anticoagulants, if you will, and it was the only one that we had until about 10 or so years ago when a new generation of anticoagulants rolled out. These newer ones are called direct thrombin and 10A inhibitors, and common brand names in the United States for this newer class are Xarelto, Pradaxa, and Eliquis. Coumadin and these newer agents are the most common medications used today in the treatment of blood clots. Now, there are a couple of other anticoagulants that you might hear the names of as well. Heparin is an important one, and a modified version of heparin called Lovenox is another one. Now, heparin can only be given IV, and it's a medicine that we reserve for hospital use only. Lovenox, on the other hand, is injected underneath the skin, kind of like insulin, and it can be taken at home. And we use Lovenox in some select cases when the oral agents, like the Coumadin options, are not good options. Now, the majority of patients, however, these days do end up getting put on Coumadin or one of the newer agents, so that is by far the mainstay of treatment. However, I want you to be aware of the risk of bleeding when using these anticoagulants, because we don't want to be giving patients a blood thinner for a clot when the risk of bleeding outweighs the risk of the clot. It's that whole risk to benefit ratio thing that I talked about in the previous video on diagnosis. But having said that, we don't really have very good, widely accepted tools to assess the risk of bleeding. So a lot of clinicians, such as myself, use our clinical judgment on that question. And you might ask, well, what's the big deal with bleeding? Why am I even talking about it? If someone gets a cut and they start bleeding, why can't we just put some pressure on it, like you see in the movies? And yeah, you could do that if the bleeding is superficial, and it will work pretty well, but superficial bleeds are not the kind of bleeds that we're actually concerned with. The kind of bleeds that keep us up awake at night are internal bleeds, particularly bleeds that occur in the brain. Now, these brain bleeds might occur as a result of a fall and subsequent trauma to the head, but they could also be spontaneous, and so this consideration of bleeding is not a trivial concern. The kind of patient who might not be a good candidate for a blood thinner, even though they have a blood clot, is someone who is weak and frail and prone to falling, because a fall can result in head trauma and potentially catastrophic bleeding in the brain. Another example might be someone who recently had a bleed from their gut due to an ulcer, for example. So putting a patient on an anticoagulant, before we do that, we have to consider the risk of doing so and then determine if the risk to benefit ratio works out. Now, once we start a patient on therapy, the next question is, how long do we keep them on therapy? How long do we keep giving them the anticoagulant? And in order to go about understanding the answer to this, we have to first define the notion of provoked versus unprovoked clots, because it makes a difference in the duration of therapy. A provoked clot is one that has resulted because of some cause that we can point a finger to and say, this is why the clot occurred. And common examples are recent trauma or surgery, or the use of oral contraceptive pills, or some prolonged period of immobility. The idea is that if we can find a cause, and if that cause is reversible, then the treatment for the clot will be shorter, and we will simply try our best to prevent that cause from happening again. So in the situation of a provoked clot from a reversible cause, the data consistently and clearly supports using anticoagulation for a minimum of 3 months. And in this scenario, there is consensus. But what if the clot is unprovoked? In other words, what if we can't find a single risk factor that we can point a finger to? Now, in those cases, what we tend to do is we like to anticoagulate for a longer time, at least 6 months, and more likely a year. And the rationale is that if we can't find a cause, then there's no risk factor that we can manipulate to our benefit. So as long as there isn't a high risk of bleeding, we go ahead and we commit to a longer duration of therapy. Now you might ask, well, what happens after that 1 year is over? Is it safe then to stop the anticoagulation? And the answer is that it's complicated and we don't really know for sure. So for example, if someone had a massive PE and it caused a lot of heart strain when they had it, it would make sense, in my opinion, to keep the patient on an anticoagulant for maybe several years. Now, I'll tell you that there's not great data to support this position of mine. Again, it all boils down to this being a judgment call and assessing the risk to benefit ratio for each particular patient. There are going to be situations where the therapy is definitely going to be longer than a year and could very well be lifelong. So one scenario is, for example, if the patient has active cancer. As you'll recall from my first video, cancer is a well-recognized risk factor for blood clots. So as long as the patient continues to have cancer, they will continue to be at risk of blood clots. So it makes sense to keep them on anticoagulation as long as they have the cancer. A second scenario could be if they have recurrent clots. And what I mean by that is if the patient gets a clot, they're placed on anticoagulation, and then when the anticoagulation is stopped, they get another clot again. Those patients will need lifelong anticoagulation, and in those cases, the anticoagulation will only really be stopped if their risk of bleeding becomes unacceptably high as they get older. A third scenario would be if they have a blood clot and then they are diagnosed with a genetic mutation like factor V Leiden or prothrombin mutations. In those patients, the cause of the clot can be fixed because we can't cure these mutations, at least not yet anyway, and it would make sense for those patients to be on lifelong anticoagulation. There's also a third treatment option that is called inferior vena cava filters, or IVC filters, and I think we should go over those as well. So first of all, the inferior vena cava is a large vein that receives almost all of the venous blood of the body from the waist on down. Sometimes we consider putting in a mechanical filter-like device into this vein, and this device is then called the IVC filter. The idea is that if there is a lower extremity DVT, then if that DVT dislodges and it starts making its way up into the lungs, then this filter will intercept the clot, and at the very least, we'll have prevented the DVT from turning into a PE. So that's the only advantage that it confers. And I'll tell you that the data on IVC filters is quite mixed, and there's some practitioners that I've run into who believe that it doesn't really help at all, and it can do more harm than good because IVC filters have their own particular set of complications. The one time that IVC filters might be considered is if a patient develops a clot, but we are unable for some reason to give anticoagulation. So this might be a situation where the patient is at an extremely high fall risk, or if they recently had a history of bleeding from the gut, or if they recently had a history of bleeding in the brain. So in those scenarios, we could make the argument that anticoagulation would be too risky, and we would just consider putting in the IVC filter as our best alternative option. But just so you know, the data supporting IVC filters overall is not terribly robust. Now let's switch gears for a moment and talk a little bit about clot-busting medications, also known as thrombolytics. A lot of my patients have asked me why we don't just use a medicine to bust a clot. And that's a fair question because most hospitals do have these clot-busting medications. And the main answer to this is that the risk of bleeding from thrombolytics is much higher than for anticoagulants. So we use thrombolytics sparingly and only in very select cases. So one situation that we might use a thrombolytics in the case of a PE is if we feel that the heart is getting very strained by all that clot burden. And that strain usually has to be very obvious for us in the moment for us to make the call and give thrombolytics. So here I'm talking about things like a sudden and dangerous drop in blood pressure or great difficulty in getting the patient's oxygen levels up. Another circumstance would be if the heart actually stopped, in which case we would consider giving the thrombolytic if it was available as we were actively engaged in resuscitation efforts. And now when it comes to DVTs of the legs, one of the situations that we might consider giving a thrombolytic is a condition that's called phlegmasia cerealia dolens. Now, don't ask me how they come up with these names, but this is a situation where essentially the circulation system to the leg is shut down because there's so much clot burden in the veins. Arterial blood is being delivered to the leg, but nothing is coming back from the leg because the veins are completely blocked. This results in massive congestion and enlargement of the limb, and there's a real danger of losing the limb altogether if we don't work fast to open up the clots. Now, this is a very rare condition, and in my 12 years of practice, I've only seen it once or twice. But it highlights the idea that the only times that we would consider giving a thrombolytic or clot-busting medication are in situations where we feel that there's a loss of limb or life definitely on the table. So that kind of wraps up my series on DVTs and PEs. If you have any specific questions on anything that I've talked about here or in the previous video, please go ahead and just leave it in the comment section. I'll get back to you. If you found value in this video, please go ahead and click on that like button. And as always, I will see you all in the next video.